Good afternoon, aspirants. Good afternoon, Asif sir.
Good afternoon.
Sir, we shall begin the session. Also, more students will be joining us.
Yesterday we have completed till 10 and today we will start from 11. 66-year-old lady is admitted in intensive care unit with acute respiratory distress. She has a past medical history of end-stage renal disease requiring thrice weekly hemodialysis, non-ischemic dilated cardiomyopathy, left ventricular ejection fraction is very poor, 20, type 2 diabetes, systemic hypertension. Usually you will get this type of cases in your real life scenario, and she's underwent scheduled intermittent hemodialysis yesterday but developed worsening of breathlessness 6 months after 6 hours after this session, and her current medication include carvedilol, Ramipril, spironolactone, aspirin, and insulin glargine. On examinations, he appeared distressed, blood pressure is low, epinephrine infusion is started, and heart rate is 122, respiratory rate is high, 32 per breath. Temperature is high, oxygen saturation 88%, on face mask 15 liter of oxygen, on verge of intubation. Patient renal bilateral diffuse crackle, so maybe the fluid overload is there. Cardiac examination, so S3 gallop, and you see the blood report, hemoglobin low as usual in CKD. WBC count little high, platelet is okay, sodium is okay, potassium little higher side, marginally high, urea is high, creatinine is high as usual, bicarbonate low, so metabolic acidosis is there, troponin little high, NT-proBNP expected, the fluid overload, so little higher side. So next is chest radiograph. So bilateral pulmonary infiltration, prominent upper lobe vessel, and suggesting flash pulmonary edema. Bedside echocardiography confirms several global left ventricular systolic dysfunction. Already ejection fraction is low. It is expected. No new regional wall motion abnormality. So there is no new insult. Which of the following would most appropriate management strategy removal of this lady? So here the question is on dialysis modality. So what you will do, which one of the following would be the most appropriate management strategy, fluid removal? So before giving answer, you have to know your patient. Your patient is hypotensive, your patient requiring noradrenaline, and patient is fluid overload. So whether you will do CRRT, SLAD, or intermittent hemodialysis तो नहीं हो, it's not possible. Urgent intermittent dialysis, ultrafiltration 1 liter. Intermittent need much more flow. So intermittent is not possible. So D, slow continuous ultrafiltration, and D can be answered, or continuous veno-venous hemofiltration, net ultrafiltration 150 ml per hour. What about B? So let's see the answer. You are right. Answer is slow continuous ultrafiltration at 100 ml per hour. Slow continuous means cough here, the CRRT modality. So when this type of patient you will get the because this patient not problem of the solute and not acidosis is very much, but the problem is due to fluid overload. So the primary goal is to remove fluid, and slow continuous ultrafiltration 100 ml per hour is the answer, because if you do more like 150 ml per hour, it causes significant hemodynamic instability. So that's one problem. And the furosemide patient is a chronic renal disease patient, depending on the dialysis. So there is no role of furosemide, and intermittent dialysis you will not be able to do. And peritoneal dialysis with 2.5% dextrose solution, it is not for in an acute setup, and it is not very effective for fluid removal. Now coming to your next question, 56-year-old gentleman in the ICU with a high-speed motorcycle accident. He has a past medical history of end-stage renal disease on thrice weekly hemodialysis, type 2 diabetes mellitus, hypertension, and peripheral vascular disease. Current medication include amlodipine, metoprolol, insulin glargine, aspirin. He sustained multiple injury, including grade 2 liver laceration, pelvic fracture, retroperitoneal hematoma requiring emergency embolization, mild traumatic brain injury with small frontal contusion, but no midline shift in the CT. On examination, blood pressure is hemodynamically okay, heart rate is acceptable range, and respiratory rate is okay, temperature is okay, oxygen saturation 2 liter 96%, Glasgow Coma Scale 14 with mild confusion, and mass he missed scheduled dialysis started due to accident. Okay, let's see. Hemoglobin is as per CKD. White cell count little higher side, platelet count is okay. Serum sodium 132, potassium is high because of he missed dialysis. Urea expectedly high, creatinine CKD patient, bicarbonate pH is low, so metabolic acidosis is there, osmolality is little high, serum lactate is 2.8 is marginally high. Let's see which one of the following strategy would be appropriate to prevent dialysis disequilibrium syndrome in this patient. So dialysis disequilibrium syndrome, I think you all know about dialysis disequilibrium syndrome. It is commonly happen during intermittent dialysis, and basically in the first time of dialysis when you are doing, but those patients who are getting for a month or year together, then it is not very common. It is usually after initiation due to large shifting of electrolytes it causes. So let's see what answer you have given. Mohammed has given A. So intermittent hemodialysis to reduce blood dialysis sodium. Okay, intermittent hemodialysis slow. And anybody, anything else? So patient, let's see again, see your patient. Patient background is hemodynamically stable, confused with oxygen, and chronic renal disease, metabolic acidosis is there. And trauma patient with you have done emergency embolization. So continuous renal replacement therapy, why not? Administration mannitol before during dialysis, it's not effective. Prophylactic endotracheal intubation before initiating dialysis, no, because the sensorium is 14, maintaining saturation and hemodynamically stable. So this can't think peritoneal dialysis as usual. I have said that Peritoneal dialysis is not very effective, especially in the critical care setting. So your answer lies between A and C. Let's see the answers. Answer is continuous renal desolvent therapy and gradual solute removal. Why? The pathophysiology of the dialysis disequilibrium syndrome involved rapid change of plasma osmolality leading to cerebral edema. When urea is rapidly removed from the blood during dialysis, it creates osmotic gradient between brain and plasma, and urea leave from brain tissue more slowly than the leave from the blood. And this gradient cause water move to the brain cell and resulting cerebral edema. Continuous renal replacement therapy provides several key advantages in this scenario. First, allow gradual solute removal over 24 hours, which maintain the osmotic gradient balance, and gentle approach prevent rapid shift of the osmolality triggered dialysis disequilibrium. So that is one advantage of CRRT over the intermittent dialysis, because when you are doing the intermittent dialysis, then the fluid saved, the blood flow on the machine, everything is very high. And the slate can also remove slowly. You can avoid disequilibrium syndrome in slate also, but here this option not given. But obviously, CRT has less equilibrium syndrome than SLADE also. Now coming to other option was A, intermittent dialysis तो नहीं होगा. Administration management, endotracheal tube, I have already mentioned. Okay. Now coming to your 36-year-old lady admitted to intensive care unit, high-speed motor vehicle accident resulting on polytrauma. Okay. Then she has medical history, poorly controlled diabetes, hypertension, obesity, body mass index 34, means obese, on metformin, ramipril, amlodipine. She underwent damage control laparotomy, small bowel perforation in contamination and the liver laceration. Her abdomen was left open, abdominal closure, uh, sorry, abdominal closure due to not done due to significant bowel edema. On examination, her blood pressure is low. So crucial things is blood pressure low on noradrenaline, heart rate is high, the respiratory rate is 16, mechanical ventilation, temperature is high, oxygen saturation 94%, FiO 2.5. So nearly your it's between 150 to 200, the PF ratio. She required multiple pending surgical intervention, peritoneal was out, evaluation, abdominal closure, next several days. Okay, the parameters showing the WBC count is high. The sodium is okay, but potassium is little higher side, urea is little higher side, creatinine is little higher side. So metabolic acidosis, lactate is high, procalcitonin high. Obviously, there is a contamination, so CRP procalcitonin high. So you are dealing with a septic shock in a polytrauma patient. Which one of the following renal replacement modality most appropriate for this lady? So lady is not given the history of CKD, but has a multiple comorbidity. Okay. So the low BP. So intermittent hemodialysis 4 hourly, no. Continuous venovenous hemofiltration, prolonged intermittent renal replacement therapy 8 to 12 hour daily, slow continuous ultrafiltration, sustained low efficacy hemodialysis, and regional citrate anticoagulation. So regarding coagulopathy is not telling anything about the coagulopathy. So which one is your answer? Victor, favor of C, prolonged intermittent renal replacement therapy, 8 to 12 hour daily, continuous veno-venous hemofiltration also can be. So it is basically question whether you will do CRRT or priest. So whether you will do CRRT or priest, nowadays it is recommended more on priest, that is prolonged intermittent renal replacement therapy. So it is represent optimal choice for complex lady due to several key consideration. One is priest combined advantage of continuous renal replacement therapy, hemodynamic stability with practical benefit of intermittent therapy and making particular suitable for patient requiring frequent interruption for surgical procedure. Prolonged intermittent renal replacement therapy is each session goes 8 to 12 hours following both adequate solute clearance and volume management, providing the schedule of dialysis. So the main advantage of the main difference between priest and CRRT, in priest there is a window period when the patient can be stay without dialysis, and it is basically this is a sled with extended sled. Priest is a extended sled. So in this extended sled, you will get a obviously sled is superior than the CRT in terms of solute and the fluid clearance because it is more faster than your CRRT. And now the newer machine coming with as effective as CRRT in the low blood pressure in terms of double inotropic support. So it can be remove it can be maintain hemodynamic stability. They can the flow rate is in CRRT 50 to as minimum as you can maintain 50 to 100 ml, and where priest you can maintain 100 to 150 ml. So so it is given you the beauty of it's like CRRT, hemodynamic stability in a very unstable patient. At the same time, it will give you the free time, dialysis free time. And particularly, it is important for this type of patient whom require multiple procedure or procedural window. Because if you give the continuous CRRT, then this patient need the anticoagulant, which may defer your surgical time. That is one thing. That's why the priest is the current scenario answer. Now coming to question number 14, the 66-year-old lady presented emergency department, 5-day history of malaise, fatigue, mild fever. She has a past medical history of osteoarthritis, treated occasional paracetamol, seasonal allergic rhinitis. 10 days ago, she visited her general practitioner for symptom of dysuria, prescribe trimethoprim sulfamethoxazole 960 milligram twice daily for presumed urinary tract infection. On current medication include paracetamol, need joint pain, and loratadine 10 milligram once daily. On examination, her blood pressure is 120 by 76. Heart rate is 88 beat per minute. Respiratory rate is 16 beat per minute. Temperature is 99. Saturation 98% on room air. Appear mildly uncomfortable but is alert oriented. She has faint maculopapular rash on her tongue and mild bilateral ankle edema, but the remainder of her physical examination are unremarkable. So blood picture lab test is eosinophil count is little high, platelet is little high, potassium is okay, urea is little high, creatinine is little high, CRP is high, ES are also high. So you are dealing with a chronic disease, complement C3 level, okay, complement 4 is okay, Na negative, and ANCA negative. So you are not dealing with vasculitis. Okay. So next. So which one of the following urinary finding would most likely be present in this lady? So dysuria, the main allergic rhinitis, visited urinary. So dysuria patient symptom is dysuria. Okay. So let's see. Envelope separate crystal with polarizing. So yes. So what will be your answer? Victor. Victor is given C for this answer. Aditya Sharma B. White blood cell cast with eosinophilia. Okay. So anyone can unmute yourself and you can tell me that what problem you are thinking. Why it is that's why then it is easy to answer. So anyone can Ankita, you have chooses B, eosinophilinuria. So it might be a correct answer, but why? The reason. Ankita, guess answer or you know? So let's see.
Drug induced
Yeah.
necrosis or something.
So
It can be interstitial nephritis.
yes. Uh,
Although,
interstitial
although you,
nephritis is the acute
yeah,
interstitial nephritis is a correct answer. That's why in acute interstitial nephritis, you will get the WBC cast, and that's why in this question they have given the eosinophil count also. So that is your key point because you have seen the other question also they have not given the eosinophil count. So that is one of the keyword on this question. And acute interstitial nephritis presented with a rash, uh, fever. Oh, শামসাদ খুব আর্জেন্ট না হলে আমাকে পরে ফোন করো আমি একটা ক্লাসে আছি
ওকে স্যার
খুব
ঠিক
যদি
আছে
আর্জেন্ট না হয় পরে ফোন করো ঠিক আছে
ওকে স্যার ওকে 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 থ্যাংক
Yeah. So most common causative agent is drug-induced hypersensitivity reaction. And urine analysis, one of the key features to find out the caste. And eosinophil urea is one of the marker for acute interstitial nephritis. And the other vasculitis marker is negative. So let's see that other envelope separate crystal where you will get ethylene glycol toxicity. You will get the envelope separate crystal and polarizing property. Muddy brown cast where you will found acute tubular necrosis. So acute tubular necrosis is present in your any nephrotoxic agent causing these things or your pre-renal failure like hypotension, sepsis, and nephrotoxic agent can cause. The presence of eosinophilia and rash point away from acute tubular necrosis here. Red blood cell cast, you will get the acute glomerulonephritis, fatty cast and oval fat body is typically causing significant proteinuria such as minimal change disease or membranous nephropathy. So, sorry, membranous nephropathy. So the lady presented this differential diagnosis you have to know to identify the causative agent. Now coming to 67-year-old gentleman is admitted to intensive care unit. Progressive confusion, lethargy, decreased urine output over 72 hours. Past medical history include diabetes type 2 diagnosed 15 years ago, diabetic nephropathy, hypertension, coronary artery disease, previous myocardial infarction, and peripheral vascular disease. He had an episode of contrast-induced nephropathy following coronary angiography 6 months ago, from which he partially recovered. His current medication include metformin, glyclazide, ramipril, bisoprolol, aspirin, atorvastatin. On examination, blood pressure is high. Heart rate is 92, and respiratory rate is 24, and temperature is 100, and your oxygen saturation 94% room air. He appeared volume overload, bilateral pitting edema, bilateral fine crepitation in both lung base. So diabetic nephropathy patient with hypertension develop nephropathy further due to the exposure of contrast, and now there is a symptom of fluid overload. And sodium is low, potassium is high, chloride normal, bicarbonate low, so there is a metabolic component. Urea creatinine as usual high, EGFR is 12, serum magnesium is maintaining, phosphate is maintaining, little higher side, pH is 3.2, mild acidosis, blood glucose is little high. So which of the following electrolyte abnormality most likely responsible for current clinical presentation? Hypomagnesemia, hypokalemia, hyponatremia, hypophosphatemia, hypochloremia. So what is happening here? Appear volume overload, bilateral pitting edema, and bilateral fine crepitation. So answer please. Yes. Victor has given D, hypophosphatemia. Phosphate is 2.2. C. Mohammad Chaudhary is a hypomagnesemia. C has given Victor hyponatremia. Okay, what problem he is suffering for? Hmm?
So it looks like he has flash pulmonary edema.
Okay, why flash pulmonary edema? BP is high, that's why.
No, sir, because he has PVD and MI as well. So in that case, there are increased chances of getting him into flash pulmonary edema, and that is causing secondary hyperaldosteronism and low sodium level.
Acha. So let's see. So your answer is C, or which option you have taken? C,
C,
hyponatremia.
hyponatremia. Yeah.
So let's see. Yes, you are correct, but the explanation is a little different. The gentleman is symptom consists several hyponatremia and sitting advanced CKD. and decreased sodium level 128, his neurological symptom confusion, lethargy, hyponatremia, primary electrolyte disbalance causing current presentation. And in CKD lose their ability to maintain normal fluid and electrolyte homeostasis. Several mechanisms contribute develop hyponatremia in this setting. One is that impaired free water, so dilutional hyponatremia due to fluid overload, reduced sodium reabsorption in the proximal tubule, which cause hyponatremia, ADH secretion reduce, so inappropriate antidiuretic hormone secretion due to reduced clearance, volume overload leading to dilutional hyponatremia I already mentioned, and multiple medication effect, particularly ACE inhibitor ramipril, and causes the hyponatremia. So the following option can be ruled out, explained below, that hypomagnesemia is not there. Magnesium was 1.1. Hypokalemia was not there, 5.5. And hypophosphatemia, the hyperphosphatemia rather, there was. And chloride level 94 is likely okay, and secondary to metabolic acidosis, it is little lower. Now coming to question number 16, 48-year-old gentleman brought to the emergency department following high-speed motor vehicle collision. His past medical history include insulin dependent diabetes mellitus 18-year and microvascular complication already present, hypertension 12-year, end-stage renal disease, thrice a week dialysis for last 3 years, peripheral vascular disease already present. He last received dialysis 48 hours ago. His current medication include insulin glargine, insulin aspart, amlodipine, carvedilol, and sevelamer 800 milligram 3 times daily with meal. Initial assessment revealed Glasgow Coma Scale 14. So vital sign blood pressure is very high. Heart rate also high, respiratory rate 22, temperature 99, mild fever, oxygen saturation 94, and intracranial pressure is 22. So normal range is 5 to 15. So intracranial pressure little higher side. CT, a reveal right-sided acute subdural hematoma. This is 12 millimeter thickness and 4 midline shift, right temporal bone fracture, and right femoral shaft fracture. Laboratory investigation, sodium, potassium is little high, chloride is low, sodium bicarbonate is low, metabolic acidosis, urea high, creatinine high, hemoglobin 9.8, pH is 7.2, and lactate is little marginally high. So the which of the following renal replacement therapy modality most contraindicated in this clinical scenario? CRRT, PD, ED, ISD. So guys, your answer. Mohammed said E, peritoneal dialysis. Okay. So Victor is B, extended dialysis. Why not extended dialysis? E, why continuous renal replacement therapy? Though continuous renal replacement therapy is slow, but so here the catchment area is that patient have hemodynamically stable blood pressure is okay, but the catchment area is here, the ICP is high, and second subdural hematoma is there. So which actually, this question asking which modality has not changed the ICP much, or rather, it doesn't cause bad effect. So which one will cause most contraindicated, means which one is cause more problem on the ICP? Actually, question is which one, which modality will cause more adverse effect on A. Now you want to change your answer, Ankita? Oh, sorry, Ankita, no, Anika. Anika Ravan. Anika, you want to change? Or John, you want to change? No.
Yeah, I want to change.
Yes. Now you
Okay.
tell me which one? Which one will cause more effect on your ICP? Yes. 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 So intermittent hemodialysis, actually in a complex trauma scenario where the ICP is high, the intermittent hemodialysis is strongly contraindicated, because previous question we have discussed that intermittent hemodialysis is a fast remove the urea and which cause cerebral edema. So it causes more and more increase of your ICP. Already ICP is raised, so you will not give the intermittent dialysis. Okay. Now coming to next question. 66-year-old gentleman presented emergency department with progressive abdominal pain, fever for last 4 days. His past medical history include is a CLD patient, child's book cirrhosis secondary to hepatitis C, esophageal varices there, previous bleeding, type 2 diabetes and hypertension. His current medication includes spironolactone, furosemide, propranolol, metformin. On examination, his blood pressure is 108 by 58, heart rate 98, respiratory rate 20 beat per minute, temperature is 101 degree Fahrenheit, oxygen saturation 96%. On room air, physical examination revealed marked icterus, spider navy, plumbar erythema, shifting dullness, all are features of CLD, and diffuse abdominal tenderness without guarding diagnostic paracentesis reveal cloudy ascitic fluid, and neutrophil count is 2800. So you are dealing with a spontaneous bacterial peritonitis. Okay, let's see laboratory result. As usual, WBC count is high and platelet is low, INR is high, sodium is low, potassium okay, creatinine little, higher side or normal, barn is little high, bilirubin is high, albumin low, and milk sodium course is 22. Okay, let's see what exactly asking. Which one of the following therapeutic intervention is the most appropriate to prevent hepatorenal syndrome in this gentleman? So another area in renal system is hepatorenal syndrome, which is very common question you will get, the type of hepatorenal syndrome and the question on the treatment of hepatorenal syndrome. You might get hepatorenal syndrome in A type question or K type question. So you have to have the depth of knowledge of hepatorenal syndrome, how the diagnostic criteria and the management and the type of hepatorenal syndrome and the mortality, which one have high mortality, type 1 or type 2. So appropriate prevent hepatorenal syndrome, midodrine, octreotide, terlipressin, albumin, and norepinephrine, continuous infusion. So फटाफट option you send, yeah. Rawat is given C, terlipressin 1 milligram every 6 hours plus albumin. Yes, little closer. Or albumin, only albumin. Also. So, yes, get back to your question that is a spontaneous bacterial peritonitis. This is the picture. Patient not in hepatorenal syndrome yet. You are trying to prevent hepatorenal syndrome. So, would you like to give terlipressin or octreotide? It is the treatment of hepatorenal syndrome when it is established. So now you want to change your. So, what is hepatorenal syndrome? Actually, when the renal function is absolutely okay, due to your CLD or chronic liver disease, pancreatic vasodilatation, the afferent flow is the kidney perfusion is low. That's why there is a low urine output.
Now,
Creatinine is little bit high in hepatorenal syndrome, but the in kidney biopsy, kidney is absolutely okay. So the treatment is increase splanchnic vasoconstriction by your octreotide or terlipressin, and along with increased volume by giving the albumin. So here you are not this patient is not having the hepatorenal syndrome because there is no comment on the urine output. So will you give to albumin? Yes. The correct answer is albumin, who has given, Mohammed has given. Yes, the patient's suffering from spontaneous bacterial peritonitis. So, spontaneous bacterial peritonitis treatment is giving antibiotic, broad spectrum cephalosporin, along with the, you have to give the albumin to maintain the oncotic pressure to prevent your to maintain the your renal perfusion. Okay. So midodrine, usually we give midodrine in a CLD patient when the blood pressure is low, but there is no supporting evidence that it preventing hepatorenal syndrome. And octreotide, somatostatin analog, terlipressin, these all are treatment of it has a role of in established hepatorenal syndrome, but there is no literature support it can be used as a preventive measure. So only albumin is the till now accepted. Next question. 24-year-old gentleman brought to the emergency department his roommate with progressive confusion, fever, and seizure. His past medical history include migraine headache, occasional cannabis use. His roommate report that the gentleman developed fever and severe headache 2 days ago following vomiting and altered mental status this morning, cumulating in a generalized tonic-clonic seizure. His current medication include sumatriptan 50 milligram for migraine, and blood pressure is okay, heart rate is tachycardic, respiratory 24, temperature little higher side, 101 degree Fahrenheit, oxygen saturation 98%. He appeared confused in Glasgow Coma Scale 13, neck rigidity is there, positive cardiac and Bardenzi sign. So patient might have bacterial meningitis. Okay. So WBC count 14,000, hemoglobin 14, platelet count okay, serum sodium, potassium okay, creatinine is okay, blood urea nitrogen is okay, C-reactive protein little high. So cerebrospinal fluid level opening pressure is high, protein is high, glucose is low, CT scan, no acute intracranial pathology. The gentleman started on intravenous acyclovir, vancomycin, ceftriaxone. After 48 hours of treatment, mental status improved significantly but developed oliguria, nausea, and bilateral flank pain. So repeat laboratory tests, serum creatinine increase, okay, blood urea nitrogen increase, potassium increase, urine specific gravity, pH is 6, protein is isoproteinuria is there, RBC is there, numerous bifragmented needle shaped crystal. So, gentlemen, what medication causing acute kidney injury? Do you think cannabis can do the kidney injury? You can unmute yourself.
Don't know, sir.
So all medical hostels guys will be will have the acute kidney injury by that time because everybody use cannabis. So what is the causative agent here? D. Sumatriptan. Yes, A can be. Why not vancomycin? So remember
I
vancomycin.
ticked vancomycin because I think it does.
Yeah, so I'm trying to confuse you. So
Mm.
vancomycin, ceftriaxone, all cause AKI, but acyclovir is notorious among all this. So whenever you use acyclovir, it is a very nephrotoxic and its nephrotoxicity depend upon the volume status of the patient because it formation intertubular crystal. So this intertubular crystal formation is causing the acute kidney injury. So adequate hydration is very important. Slow intravenous infusion, dose adjustment based on renal function and maintains good urine output. So your marker is good urine output. This question, what was the keyword? This keyword is your numerous bifragmented needle shaped crystal. So in vancomycin or ceftriaxone can cause acute kidney injury, but not so early. But acyclovir, yes, it cause because if the volume status is volume depleted case, the acyclovir produce this crystal, and this crystal is deposited in the nephron tubules, and it causes the acute kidney injury. Yeah. So cannabis can cause, cannabis has been reported cause of kidney injury through calcium oxalate crystal deposition. Natural cannabis use not been seen associated with crystalline nephropathy. So which you are getting naturally. In India, it is called Bhole Baba Ka Prasad. So it's not cause harm to your body, but definitely it cause lot of harm to your lungs. Now coming to the 19 number question, 72-year-old gentleman is currently in your intensive care unit, complex right hepatectomy for metastatic colorectal cancer. His past medical history include diabetes, hypertension, coronary artery disease, and also stage 3 kidney disease. His current medication include metformin, Ramipril, bisopril, aspirin. During surgery, his experience significant blood loss requiring transfusion 4 unit of Paxil, aggressive fluid resuscitation. balanced crystalloid solution, his blood pressure dropped to, okay, intraoperative noradrenaline support required, postoperative day 3, his blood pressure was normal, heart rate is okay, respiratory rate is beat per minute, temperature is little high, saturation maintaining with 0.4%. He remained mechanical ventilated but hemodynamically stable without vasopressor support. His urine output has progressively declined past 24 hours to 5 ml per hour despite adequate filling pressure, central venous pressure. Okay. Let's see laboratory test. The count is little high, hemoglobin okay, platelet is acceptable. Only potassium is little higher side. Serum creatinine is little higher side. So serum urea also little higher side. So develop AKI. Bilirubin is high and is maybe this perioperative hypotension can cause this AKI. Diagnostic test most appropriate initial investigation to evaluate his acute kidney injury. Renal ultrasound, Doppler study, contrast enhanced CT, serial serum urea creatinine measurements, spot urine sodium concentration, and this technetium 19M make renal scan. So which one? Aditya has given B. Anybody आप AKI में contrast दोगे आदित्य? Rawat has given D. Spot urine sodium concentration. Okay. Urine output only 5 ml. D. Everybody is giving D. Very good. So urine output is very low. John has given C, serial urea creatinine. जितना urea creatinine करोगे उतने भी तो it will increase. So why not technetium 19M? And why not renal ultrasound with Doppler study? It is very much non-invasive and it will not needed any contrast.
So to exclude renal artery stenosis, for that reason, A, you're saying?
Yeah. So first of all, what we do when the patient suffer for acute renal failure, we do first the USG QV and the ultrasound study, the Doppler study, whether that blood flow, renal blood flow is okay or not, and what is the corticomedullary changes. So whether you are dealing with the acute kidney injury or the CKD, the chronic kidney injury. So, and this is ultrasound is very much non-invasive things and it not cause any abnormality on the, further abnormality. So you can find out the kidney size and echogenicity. By that you can differentiate AKI or CKD. And second is presence of hydronephrosis or obstruction is there, or whether it is due to renal cause, you can identify renal arterial and venous flow pattern, potential post-operative complication like retroperitoneal collection, assessment of hepatic vessel given recent liver surgery. These all are, and also you will get another information about the abdomen. So this advantage over there, and why not contrast? Because contrast is further worsen your renal function. And what about the serial serum urea creatinine? This measurement is essential in progressive kidney injury, but it will not provide underlying cause why this kidney injury happened. Spot urine sodium is differentiating pre-renal from the intrinsic renal cause of acute kidney injury, but tests provide no anatomical information identify post-surgical complication. So in this scenario, spot urine sodium is not an appropriate answer. And technetium NNM provide the functional information. It is too specialized and resource intensive to use initial investigation. But actually, this is not available most of the center, and it is need very specialization skill to identify. The next question is 57-year-old patient, emergency department, progressive lower extremity weakness, hoarseness over past 2 days. She has a medical history of end-stage renal disease secondary to diabetic nephropathy, hypertension, requiring hemodialysis, time week 3 times a week for past 4 years. She report missing her last 2 hemodialysis session due to logistic issue, including transportation challenges, scheduling conflict of the dialysis center. Okay, bagara bagara. Her urine output has been negligible since the initial renal replacement therapy. She also mentioned mild nausea but denied chest pain, shortness of breath, and palpitation. Her current medication is amlodipine, insulin, sodium bicarbonate, calcitrol. On examination, our vital sign, blood pressure is okay, heart rate is okay, respiratory rate is okay, temperature is okay, oxygen saturation also okay. Now, laboratory investigation, sodium low, probably dilutional hyponatremia is going on, potassium is very high, chloride is low, carbon dioxide is 18, so doing hyperventilate, blood urea nitrogen is 68, creatinine is high, calcium is okay, glucose is little higher side. So ECG reveal peak T wave, obviously potassium so high, regular rhythm, no evidence of worsening QRS complex or bad arrhythmia. Due to logistic constraint, there is a delay approximately 2 hours before initiating emergent dialysis. Which one of the following agent will reduce serum potassium most rapidly? Albuterol nebulizer, intravenous calcium gluconate, intravenous furosemide, insulin with glucose, sodium polystyrene sulfonate. तो ये लोफा क्वेश्चन है. जो लोग आईसीयू में काम करता है, एवरीबॉडी नोज. सो इसका मैकेनिज्म क्या है, अब बताओ. एवरीबॉडी हैज गिवन इंसुलिन एंड ग्लूकोज. उसके साथ साथ हम लोग माने वी डू आल्सो समथिंग एल्स टू. Yes, you want to save the potassium intercellularly. That's why
Shift of potassium within the cell along with glucose.
yes. And before that, what you give here is calcium gluconate. How calcium gluconate works?
Stabilize the myocardium.
Yes. So here, the first thing that already in your ECG peak T wave is there. So you have to stabilize the myocardial membrane first and reduce the potassium level. Intravenous calcium gluconate stabilize myocardial membrane potential percentage against life-threatening excessive hyperkalemia in cardiac condition. Calcium also act rapidly once it within 1 to 3 minutes, but does not reduce potassium level. So for potassium level reducing, insulin and glucose is the ideal, but it takes 10 to 20 minutes and already you have a ECG changes. So the correct answer is here intravenous calcium gluconate followed by insulin glucose. So intravenous furosemide has no role because already is a end-stage renal disease, and albuterol nebulization also shift the potassium, but it is very slow. So it is not effective here. Okay. So next, 20-year-old university student is brought to the emergency department following high-speed head-on motor vehicle collision 2 a.m. He was the driver and was trapped in the vehicle for 3 hours before extraction. He has a history of well-controlled type 1 diabetes from his age 12 year, mild asthma requiring occasional salbutamol inhaler, depression treated with sertraline 50 milligram daily. His current medication include insulin glargine subcutaneously at bedtime, insulin aspart 4 to 6 units subcutaneously with meal, sertraline 50 milligram oral daily, and salbutamol inhaler 2 puff as needed. On examination, he has crush injury on his right lower extremity, significant swelling and compartment tension. His vital sign, blood pressure is low, heart rate is high, and respiratory rate is high, temperature high, since saturation room are 94, point of care glucose is 210. So creatinine kinase is very high, creatinine is higher side, potassium is high, sodium is okay, metabolic acidosis, bicarbonate low, serum lactate is high, myoglobin is 85. So you are dealing with compartment rhabdomyolysis kind of thing, and myoglobin is very high. Let's see which of the following intravenous should have been initiate emergency medical service field to best prevent acute kidney injury in this gentleman. Normal saline with sodium bicarbonate, balanced crystalloid, hydroxyl starch, mannitol normal saline, low dose dopamine infusion. I think previously similar type of question you have already done. So last question was modality of treatment and what you will do. And now this question is which saline you will give? Normal saline with sodium bicarbonate or balanced crystalloid solution and hydroxyl starch. So B, balanced crystalloid solution. Everybody is B. Why not normal saline and the sodium bicarbonate? Let's see. So ideally, you have to give the balanced crystalloid solution in this, the main motto of the treatment to maintain well hydration and maintain the urine output at least more than 1 ml per kg body weight. And so there is, you need lot of fluid to give. And it has been shown that if you give the normal saline, which is not normal, it contain lot of sodium and the chloride. This chloride cause hyperchloremic metabolic acidosis, which enhance the acute renal failure. And in this problem is myoglobinuria, and this myoglobinuria can cause obstructive cast in the renal tubule, and they causing the acute renal failure. So you have to do the more diuresis. So balanced crystalloid has more physiological chloride content compared with the normal saline. And furthermore, some balanced solution content buffers such as lactate or acetate can help address the metabolic acidosis. Buffering capacity combine their ability to improve renal perfusion and make them particularly suitable for initial management of the crash injury. Okay, and normal saline, as I said, that the chloride content is very high, which is called hyperchloremia, hyperchloremic metabolic acidosis, acute kidney injury, starch, big no, mannitol normal saline. Mannitol can exacerbate extravascular volume depletion to osmotic diuresis. So fast treatment is give adequate fluid fast, no diuresis. So now coming to 22. Question number 22, 44-year-old gentleman brought to the emergency department by ambulance after being found unconscious outside pub. He has a history of alcohol dependence syndrome, liver cirrhosis, recurrent episode of acute pancreatitis. He takes spironolactone, propranolol, thiamine, and he has recently treated with spontaneous bacterial peritonitis, but the hospital against medical advice 3 days ago, okay, left from the hospital with DAMA. On examination, he appeared malnourished, temporal wasting, intermittently agitated, his blood pressure, heart rate, respiratory rate, temperature is more or less okay. Temperature is little high, oxygen saturation on the room here, spider navy, plumbar erythema, ascites, shifting dullness, bilateral, all features of CLD is there. So let's see the laboratory tests. Hemoglobin 9.2, WBC count is high, platelet count as usual low as per CLD. Sodium is 132, potassium okay, chloride is little low, bicarbonate is low. So there is a metabolic acidosis, burn is high, creatinine is little high, plasma glucose is low, anion gap high, so high anion gap metabolic acidosis, osmolar gap 10, and serum lactate due to the alcohol, osmolar gap is 10. Serum lactate is high, serum beta hydroxybutyric acid. So ketone is present, ethanol is present, ammonia is high, INR is 1.8. So blood arterial gas is metabolic acidosis, hyperventilating, PaO2 is okay, bicarbonate 14. So high anionic gap metabolic acidosis with high osmolar gap due to the alcohol. So which one of the following causes metabolic rate? Key answer, Muhammad is E, diabetic ketosis and hepatic decompensation. And Ankit, this Anika has given B, metformin associated lactic acidosis. And Muhammad has given E, Anika is D, diabetic ketoacidosis. This patient is diabetic is okay, but do you think it is due to diabetic ketoacidosis? Because let's see that the key point of here is patient unconscious outside the pub. So Joe, the banda who is in the outside of pub, he must has taken some alcohol. Okay. And history also suggesting that alcohol dependency syndrome है बंदा का बिना अल्कोहल का उसका चलेगा नहीं. Okay. So this is a malnourished and temporal wasting means there is the ketosis is due to the malnourished things, and malnourished because he's not taking meal. CLD is there, metabolic acidosis, beta hydroxybutyrate ketone is present, so there is a ketosis. So yes, pH is low. But where is the sugar? Sugar is very high. The sugar is low. So blood glucose is low. So how it can be a diabetic ketoacidosis? So it is a alcoholic ketoacidosis with concurrent lactic acidosis. So this gentleman presented complex metabolic derangement characteristic alcoholic ketoacidosis combined with lactic acidosis with is commonly coexisting in the chronic alcohol. This ketoacidosis is more or less is a starvation ketoacidosis. He's taking only alcohol, not food, good food. So diagnosis supported multiple features, the severe anion gap. You will also get the diabetic ketoacidosis anion gap. You will get the beta hydroxy is the same, and hyperlactatemia is common in diabetic ketoacidosis also. This gentleman has chronic alcohol use, recent drinking episode found outside the pub, and current ethanol suggested period of drinking followed by cessation and typically precipitation, the alcoholic. Yeah. So, and the pathophysiology involve multiple mechanisms during alcohol withdrawal, concurrent regular hormone like glucagon, cortisol, and catecholamine increase while insulin level decrease, and hormonal molecule combined with prolonged fasting, depleted glycogen store, promote lipolysis, subsequent ketogenesis, and simultaneously alcohol metabolism increase in NADH-ND ratio, promoting lactate production and impairing gluconeogenesis, experiment mild hypoglycemia seen, and relatively normal osmolar gap despite significant ketoacidosis absent, visual symptoms, severe neurological deterioration make toxic alcohol ingestion most likely, and malnourished state, liver dysfunction, possibly early sepsis, and this component. Why not diabetic ketoacidosis? This gentleman is hypoglycemic. This is the first thing, the hypoglycemic. Diabetic ketoacidosis, we got in a hyperglycemic state. So there is no known history of diabetes pattern, recurrent hypoglycemia, and ketoacidosis is more typically alcoholic ketoacidosis than the diabetic ketoacidosis. Now coming to 23. Question number 23, 69-year-old gentleman transferred to your ICU following transurethral resection of the bladder tumor due to transitional cell carcinoma. He has history of poorly controlled diabetes mellitus, hypertension, chronic kidney disease, stage 2. Current medication include metformin, amlodipine, and lisinopril. During 3-hour procedure, 25 liter of glycine solution were used in bladder irrigation. Recovered in the recovery room, he became increasingly drowsy and subsequently developed generalized tonic-clonic seizure. And after receiving lorazepam intravenously, intubated, airway protection, transferred to your ICU. On examination, his blood pressure is 168/92, heart rate is 88 beat per minute, respiratory rate 14, temperature is normal, oxygen saturation 100%, FiO 2.4, neurological examination reveal absent cough and gag reflex and generalized hyperreflexia. So sodium is low, potassium is high, chloride is low, serum bicarbonate is low, so metabolic acidosis. 1 is little high, creatinine is okay, glucose is okay, little higher side, osmolarity is low, urine osmolarity is very low, urine sodium is low, hemoglobin is okay, plasma free hemoglobin is okay. So you can unmute your mic and you can tell what problem you are dealing with.
Hyponatremia for bladder irrigation.
Hyponatremia for bladder irrigation. So TRP syndrome, very good. So emergent cytogram reveal intraperitoneal extravasation of contrast. Okay, which of the following most appropriate? Managing gentleman electrolyte management, initial fluid restriction, administration intravenous desmopressin, administration of 3% sodium chloride targeting sodium increase, Venovenous hemofiltration. বলো। So you are dealing with. So what is your first management?
To give him 3% sodium chloride to
অভিষেক পরে আমি অনলাইনে ক্লাস নিচ্ছি, ঠিক আছে? হ্যাঁ, 3% chloride for how many hours? 24 hours,
yeah, within 24 hours.
24 hours.
Yeah, 6 hours will be too short.
Too
You know,
short.
it will be too rapid to increase it from 116 to 124 within 6 hours.
So here you have to basically you have this QRP syndrome. So dilutional hyponatremia again there. The problem is that this patient having the generalized tonic-clonic seizure. So generalized tonic-clonic seizure. So when there is a acute hyponatremia causing seizure, what is your management? What is your management? So administer 3% chloride targeting sodium increase 124 within 6 hours. Because you have to control the seizure, and the seizure is due to your hyponatremia, acute hyponatremia. So your rate of correction will be higher. Okay.
Noted.
Yeah. So when there is a chronic hyponatremia, then you can correct slowly. But in acute hyponatremia, then first thing you have to correct rapidly till the convulsion control. After that, you go by this formulation 10 milliequivalent per day. Okay, now second last question, that is 57-year-old gentleman presented emergency department with severe lower thoracolumbar back pain radiating to the anterior abdomen, sudden onset bilateral lower limb weakness. His past medical history include poorly controlled hypertension, diabetes type 2 mellitus, chronic kidney disease stage 3, peripheral vascular disease, and previous right femoral popliteal bypass. His current medication amlodipine, perinodril, metformin, glyclazide, aspirin. Upon examination, his blood pressure is 215 by 108, heart rate is 116 beat per minute, respiratory rate is 24 breath per minute, temperature is 99, oxygen saturation is 94% on room air. Neurological examination revealed bilateral lower limb weakness, power is 2 by 5, diminished deep tendon reflex, loss of sensation below T10, dermatom. Thoracolumbar pain, okay. So hemoglobin 10, white cell 13, platelet count is 78, serum sodium 134, potassium 4.8, urea 12.8, creatinine is 16, so increase, and EGFR. Just a minute, I'm taking one call. Chandrani, আমি তোমাকে ঘুরিয়ে কল করছি, ঠিক আছে? আমি একটা ক্লাস নিচ্ছি, জাস্ট আর 10 মিনিটে শেষ হবে।
ঠিক আছে।
Troponin T is 24, lactate is high, pH is acidotic, base excess -6. So what question asking? The contrast in CCT, so type B aortic dissection beginning to distal to left subclavian artery and extending to abdominal aorta and complete occlusion below the celiac trunk. Gentlemen undergo emergency thoracic endovascular repair. Lumbar cerebrospinal fluid drainage catheter is placed prior to anesthesia. Induction for spinal cord protection following successful stent deployment and restoration of the distal flow. Gentlemen develop broad complex tachycardia, peak T wave following ST segment elevation, lead 2-3 AVF, and hence they immediately transfer back to intensive care unit for further management. Which of the following most likely cause electrocardiographic changes? Acute coronary syndrome due to retrograde dissection, massive pulmonary embolism, reperfusion syndrome with hyperkalemia, extensive dissection into ascending aorta, and mesenteric ischemia and metabolic derangement. So another important area is your aortic dissection. So you might get a question on classification of aortic dissection. You might get a question on the complication of repairing aortic dissection like this. So what is happening here? Why? What is the problem? So problem, Anika has given D, extension of dissection into ascending aorta, and John has given C, reperfusion syndrome, hyperkalemia. Okay, Victor is D. So let's see. Reperfusion syndrome and hyperkalemia is the answer because the clinical scenario demonstrates classical presentation of reperfusion injury following reabsorption of the blood flow on previous ischemic tissue. From ischemic tissue, the blood which is more anoxic and with high lactate, and when there is acidosis, the potassium come out from the cell. This is called hyperkalemia. That's why the electrocardiographic changes, broad complex tachycardia, peak T wave, and pathognomonic of hyperkalemia can progress to ventricular arrhythmia and cardiac arrest if not treated promptly. Acha, why not? This is due to acute retrograde dissection. Although present peripheral vascular disease often have concurrent coronary artery disease, ECG changes could suggest acute coronary syndrome and rapid development of the broad complex tachycardia and peak T wave more consistent with hyperkalemia. Not for progressive type B dissection coronary artery extends. It is extremely rare. And massive pulmonary embolism, it's not because it is not suggestive, the history, and also ECG is not showing S1 Q3 T3 pattern. And extension dissection to ascending aorta is also not very common. Acute mesenteric ischemia, metabolic acidosis precipitate little different type of presentation. So therefore, it is not a acute mesenteric ischemia. The next question is 66-year-old lady presented to the emergency department with progressive abdominal pain and distension. Her past medical history include ventral hernia repair made 2 years ago, hypertension, atrial fibrillation, chronic kidney disease. Her current medication include apixaban, bisoprolol, ramipril, and furosemide. Upon examination, her blood pressure is low, heart rate is 118, respiratory rate is 28 beats per minute, temperature is high, oxygen saturation room air, her abdominal distension, generalized tenderness, high pitch bowel sound, nasogastric tube is inserted during draining of 800 ml bilious fluid over 2 hours. So recent laboratory is sodium okay, potassium is okay, little hypokalemia, chloride is okay, bicarbonate low, so metabolic acidosis is there, urea is high, creatinine is high, calcium is low, Albumin is okay. WBC count is high. Hemoglobin and serum procalcitonin is high. So blood gas showing that metabolic alkalosis, hyperventilation. So metabolic respiratory. So respiratory alkalosis with metabolic acidosis. So either yeah. So computed tomography repels small bowel obstruction, closed loop formation of pneumometastasis intestinalis. So which one of the following acid-base disorder combined base explanation this finding? So it has a three component in ABG. You see that there is the triple disorder. Why? Because this CO2 is not telling the this much of metabolic alkalosis, this much of respiratory alkalosis, though there is a acidosis is there compensating, base excess is low. So maybe respiratory alkalosis along with metabolic alkalosis along with high anion metabolic acidosis, C will be right. So how many of you agree with this? Now, when there is a mixed acidosis, let's see. When, yeah, the answer is triple disorder. When there is a mixed acidosis, how will you diagnose this? By checking the gap. The anion gap, you have to calculate the anion gap, and also you have to calculate the bicarbonate gap. So then you have to do the ratio. You will understand that whether there is a mixed acidosis is there or not. Or sometime it more obvious, like if you practice in critical care, you can understand this thing. Here the anion gap is 30. So the bicarbonate gap, if you see that bicarbonate gap is 2.5. So anion gap by bicarbonate gap 2.5. So the dictum is if it is less than 1 or more than 1. So if it is more than 1, it is an additional metabolic alkalosis. If it is less than 1, it is metabolic acidosis. So, okay, that's all about today's class.
Thank you, sir.
So I need feedback from the student also.
Sure, sir.
So it will help me to improve my classes.
It was very helpful, sir, and very good and in case of understanding and preparation to the exam. May I just ask if you could keep the question itself a bit longer to get through the actually the question? It would be very helpful. Otherwise,
Yeah, Victor, it's a good suggestion, but the thing is that it is a debriefing session. So what I expect that everybody who are attending class who have already given the exam. So it is my request to all of you, every month I will take the mock test, and it is not easy to complete 25 question in one day or 50 question in one day. Then it will be very fast class, and you will not get time to explain the every option why it is not and why it is yes. So that's why I'm keeping my lecture to take at least 15 question one day. Though initially I have allotted one class, but I have taken 4 classes to explain you in better way to make you understand and prepare this topic. That's why. So this February month again, I will put another 50 question for mock test. Please, all of you go through the mock test, give mock test, and after that you attend this debriefing session. So at least the question which I will explain, that is already you have seen. So I want to focus more on the explanation time, because in the explanation, if I give the reasoning why it is when it is true and why it is not true, along with I little bit discuss about the topic, so it will help you lot in your actual exam and preparation also. So that's there. So Fatma,
Yes, sir.
so you give question for mock test in February on by 15 or 16. Then they will give the mock test, and I will start taking the this debriefing session from 28th onward. Okay.
Sure, sir.
Okay. Thank you.
Thank you, all the aspirants. We'll join soon.